this off of there. Okay, I guess it's going to go away. So have you seen this scale before, like the relationship between acid and base? So for every like molecule of hydrogen, or you know how it travels in the bloodstream in the form of carbonic acid. So for every molecule of carbonic acid, you need 20 of bicarbonate ions. So that's the normal ratio of acid to base in our body to keep us right at 7.40. So remember when we're interpreting blood gases, it's telling me to move this away, but I don't know how to move it away. Please move this window. See right on my blood gas there how it has, please move this away?
Oh, it went away.
Because I was hovering over it with my other.
It's back now.
I know, it comes back. It's going to drive me crazy. Go away. Yeah, I don't know how to do it. Okay. Pay no attention to the, please move this away. Now it's going to disappear again. Okay. Anyway, assess the pH, right? So we're going to look at what is the blood. We get a blood gas slip. We drew an ABG. We sent it off with the respiratory therapist. They ran it. They brought us back our result, put the result in the computer. We pull it up. We want to know, what is the person's pH? Normal is 7.35 to 7.45. 7.4 is right on the money. So if it's normal, we know that at least in terms of acidosis or alkalosis, they either have a normal blood gas or they're compensating. Okay, we're going to talk about compensation today. So just because your pH is normal doesn't mean that there's not disease process going on. But we look at the pH first to determine if it's acid or base. Then we're going to look at our carbon dioxide, right? Our PCO2, our partial carbon dioxide. And normal level is 35 to 45. Remember, that's our acid, right? In our body, our lungs can get rid of that acid by exhaling. We breathe in oxygen and we breathe out carbon dioxide. And then the plants, all our green, nice, leafy plants around us, they take that carbon dioxide and they emit oxygen. So we have that symbiotic relationship with nature around us. So that whole the respiration of humans and the respirations of plants. So normal CO2 levels in our body, in our arterial blood, is 35 to 45. If I'm blowing off a lot of acid, I'm going to drop my CO2. So if it's low, then I don't have enough acid, I'm going to be alkalotic. And if it's high, like if I'm, somebody gave me too much morphine and I have.
Can you repeat that? Can you repeat that, please?
Yes.
Because it like totally like jumbled up, so I didn't hear.
Okay.
After you said what the normal carbon dioxide is, and it kind of cut out.
You bet. My lungs either blow off CO2 or I retain CO2 through my respiratory system. So normal is 35 to 45. If I'm hyperventilating, I'm blowing off carbon dioxide. I'm getting rid of it in my body. My CO2 level is going to go down. If I'm intubated and you're bagging me too much and you're hyperventilating me and my CO2 goes down, that's going to cause respiratory alkalosis because I'm losing the acid through my lungs. If you give me morphine and I have respiratory depression and I'm laying there and I'm just having these shallow respirations and I'm retaining CO2, or I have COPD and I have chronic obstruction of my lungs, or my alveoli are, I have emphysema and the alveoli are overstretched and I've lost that tone so that I have air pockets and overinflation and increased compliance of my lungs in a way that I'm not having good ventilation, I'm going to retain CO2. And the acid is going to build up and it's going to go above 45 and I'm going to have too much acid and I'm going to have respiratory acidosis. So we're going to ask ourselves with that CO2, is it normal? Is it high and do I have acidosis? Or is it low and do I have alkalosis? And that's that second part. In your med-surg book, and I can post the page number, I did post the page numbers in the quick view outline, but I can post it separately. It has this like 8 or 10 step process of look at the pH, then look at the CO2, then look at the bicarb, then look at the relationship and determine what kind of acidosis or alkalosis you have, and then determine if there's compensation. So we're on the next step. We're looking at the bicarb. What are the kidneys doing? Okay. If I'm losing base from somewhere, I'm having lots of diarrhea. You know, I'm Mr. Morrison and my colostomy is putting out all this, you know, all this bicarb. So higher like NG tubes are going, you're going to lose acid because that you're losing hydrochloric acid out of the stomach. In the intestine is where you have the bicarb secretion and everything. So if I'm losing that, then I'm losing base in stool. So I look at the bicarb. If it's low, I don't have enough base, it's acidotic. If I'm taking antacids, or I coded and they gave me too much bicarb because they knew I was acidotic and they wanted to try to correct that acidosis, but they gave me too much bicarb and now I have metabolic alkalosis, right? Too much base, alkalosis, not enough base, acidosis. So with the bicarb, if it's low, the pH is going to be low. If it's high, the pH is going to be high. So after looking at the bicarb, we're going to ask ourselves, is it normal? Remember that normal value is 22 to 26 or 28, depending on what your lab values are in your organization. You know, depending on if you send it to LabCorp or Quest or wherever, you know, they have their different parameters. Somewhere 22, 26 is perfect. So then we're going to look at, with what's going on with the CO2 and the bicarb, which one matches the pH. If it's normal, it's normal. If it's not, is it metabolic acidosis or alkalosis, or is it respiratory acidosis or alkalosis? So there's only those 4. The good part of it is there's only 4 acid-base abnormalities. So then, the good thing, though, is that our bodies do compensate. So if you have an acid-base imbalance, if you have respiratory disease, right? I have pneumonia, and I'm not breathing well, and I'm not getting rid of my CO2. So the CO2 in my body is building up, and it's 55. Normal is 35 to 45. So I've got too much acid. Now, it's going to take a while for those kidneys to kick in, maybe 24 hours. Depends on how good my kidneys function already, and how well my health is overall. So the kidneys are going to compensate. They're either going to retain bicarb or they're going to produce more bicarb. They're going to kick in. So if my pH, if my CO2 is 55, you know I'm retaining CO2. But if my pH is still normal, if it's still 7.4 or somewhere between 7.35 to 7.45, my kidneys have fully compensated for my respiratory acidosis. Okay? So if my pH is abnormal, if it's 7.3, so it's too low, right? So my CO2 is 55, my pH is 7, so we looked at the pH at 7.3, and we said, okay, that's acidotic. We have acidosis. We looked at the CO2, we saw it was 55, we know it's respiratory acidosis. we look at the kidneys, and let's say the bicarb is 28. So the bicarb's on the high end of normal, or if our parameters are 22 to 26, it's high. So we know that the kidneys are kicking in. The kidneys are retaining or producing more bicarb, and they're partially compensating, because if the kidneys were losing, if we were also losing bicarb and the bicarb was normal or low, the pH would be worse. So at least the kidneys are starting to kick in here, and so it's partially compensating. So when we talk about compensation, it's either going to be partially compensated if the pH is still abnormal, outside of your normal limits. If the pH is between 7.35 and 7.45, we're going to say it's fully compensating. It can work the other way also. If I'm diabetic, and we'll look at that. So if I'm diabetic and my bicarb is 18, because my body's breaking down ketones and I'm producing ketonic acid and it's using up my bicarb. So my bicarb normal is 22 to 26 and it's 18. First, if we're interpreting blood gases, we're going to look at the pH. If the pH is 7.4, we're going to be like, wow, this person's got a bicarb of 18, but their pH is still normal at 7.4. And we look at the person, how do you think that person's going to be breathing? What do you think, Garrett? How's that patient going to be breathing if we look at them?
I'm sorry, what was the question?
Okay, so I have a patient and they're in metabolic acidosis but their pH is 7.4 and their bicarb is 18. If their pH is 7.4, which is normal, and I'm looking at that patient, what am I going to expect with their respirations? How do you think they're going to be breathing?
I would say probably closer to normal, maybe a little elevated.
Maybe a lot elevated.
A lot elevated, okay.
Yeah, because if they don't have enough base, right, and they're acidotic, they should be acidotic, but they're blowing off CO2, right? They're Kussmaul breathing. And they've got this fruity breath because they're getting rid of ketonic. They're actually getting rid of acids through their breathing with the CO2. So, I'm going to expect if a normal CO2 is 35 to 45, I'm going to look at that gas, and it would make sense if it's 32 or 30, if they're blowing off extra acid to compensate for not having enough base metabolically. So if they can maintain a normal pH, they're fully compensating. Let's say that same diabetic, we look at that blood gas and we look at that pH and it's 7.28, and their bicarb is maybe even 16, and their CO2 is, let's say it's even down to 28, right? And they're really panting. And now we're worried they could go into respiratory failure, and they're so acidotic, they could, have alterations in their mental status. But and I don't want to get ahead of myself because we're going to talk about diabetes with metabolism, and you can't just bring down the blood sugar fast, okay? We talk about closing the anion gap, because the thing is they have too many anions and they don't have enough, they don't have enough base. They don't have enough anions. They got too many cations. And so we have to close that anion gap. And I'm going to show you what that looks like on a metabolic panel. So just know that when you're dealing with somebody in metabolic acidosis, when you look at that pH, if they're not compensating at all, if their lungs aren't compensating, then that's a bad sign, because our bodies we have that this ability to try to maintain homeostasis as much as possible. So we're going to look for either some partial compensation or that they're fully compensating in terms of their pH. So if I'm looking at that and it's 7 and the pH is 7.28 and the bicarb's 18, I'm going to know right away they don't have enough base and the pH is low and they have metabolic acidosis. Then I'm looking at that breathing, and hopefully they're breathing fast and they're compensating, right? So if it's 7.28, they're partially compensating, because if they weren't breathing fast and the lungs weren't compensating, they'd be even worse. But if they can maintain that pH of 7.4, now they're breathing, they're fully compensating by blowing off enough of the acid. Okay, trust me, just kind of try to memorize this at this point. We're going to apply it to a couple cases, but you're going to remember this, and then when you see it next semester, when we get back into peds and into clinical and stuff, you're going to see it. We're going to pull up the blood gases and look at it, and that's when the fun begins, So just kind of learn this now in terms of just memorizing the numbers and knowing that if the pH is normal, but your bicarb's off and your CO2 is off, there's an acid-base imbalance going on, but they're compensating fully if the pH is normal. If the pH is abnormal, then they're partially compensating. If the alternate factor, so if my CO2 is high and I'm acidotic, but I'm retaining bicarb and my bicarb is high, I'm trying to save more base, I'm compensating. Okay? And I'll post some practice questions so you can kind of work through this on your own. And I'll post a YouTube link also that kind of helps explain this further, so if you can kind of, at another time when you're really awake and everything and you want to watch through it a couple times until you really get it and practice with some scenarios. So remember that compensation is assessed because you're looking at the alternative agent, right? If the CO2 is high, we want our bicarb to also be high. We want more base. If the CO2 is low, then we want the bicarb to be low, right? We don't want more base. So we're going to look for the kidneys and the lungs to balance each other. So we're going to start that ABG assessment the same way. We're going to look at 7.44. That's normal. We're like, good. Hey, maybe their blood gas is normal. Oh, wait a minute. But their CO2 is 30, right? So their CO2 is low because 35 to 45 is normal. So it's base or basic. But the bicarb is not enough, right? 22 to 26 is normal. So that's acidic. We don't have enough of the base. So we know that both the CO2 and the bicarb are abnormal. So then we're going to look back at the pH and we see that the pH is more toward base. So we know that we have a respiratory alkalosis, but is it partially compensating or fully compensating? Haley McGoldrick, is it fully compensating or partially compensating? Haley McGoldrick Ruth, are you there? Ashley Smith, is it fully compensating or partially compensating?
I would say it's fully compensating because the pH is normal.
Yes, and you are correct. Even though it's a little on the high end, it is within normal limits. It's between 7.35 and 7.45, and you are correct. So they are in respiratory alkalosis. So they must be either, if they're on a ventilator, we're hyperventilating them, and it's been going on long enough that the kidneys have kicked in and are getting rid of some bicarb to offset that alkalosis. Or they've been hyperventilating for a while. Something like that is going on. This is fun, isn't it? Isn't this kind of cool? Because this is what really happens in our body. Not only is our heart just beating at every moment that we're speaking without us even have to do, and our breathing just happens. This all just happens. Our blood sugar is being regulated between 70 and 100, and we're sitting here. Probably most of us are right there at a pH of 7.4 with this whole process going on. Our lungs and our kidneys and all this is just working together so that, we're so strong and yet we're so fragile when you think of everything that just has to be happening. I mean, it really is cool. Okay, so to reiterate, compensation, right? If the pH is abnormal and you have that, either the kidneys, right, the bicarb, or the respiratory, the CO2, is altered, and you have that alternating agent at work, they're partially compensating, because if you didn't have that compensation going on, they'd even be more acidotic, or they'd even be more alkalotic. They'd be more messed up. But if the pH is normal and you have those alterations, then they're fully compensating. So at least their pH is being maintained. At least there's not a lot of cell death and things going on because their pH is within normal limits. But it doesn't mean that, right? So for example, here, pH is 7.23. We go, oh, they're acidotic, right? And then we look at that CO2 and we're like, oh, they're really acidotic. Like, were they in a pool and were they drowning, right? Okay, well, if they have a pulse, they're still alive, right? So we've got to correct this. We've got, this is your patient in the ICU, and we're very concerned about how much brain tissue has survived and how long they were under if their pH is that low, right? Because that's pretty low. But I've seen them at 6.8, and I've seen them come back fully from that, because kids are amazing. We call them either good save or bad save, right? We really look for how well they're coming back in that first 24 hours. So pH 7.23, CO2 is 68. It's not good, but the bicarb is 35, right? So the kidneys are compensating. So like I said, if the kidneys weren't producing more bicarb or retaining that bicarb, that pH would have even been more acidotic, even more cell death. So they're partially compensating. So this is your respiratory acidosis with partial compensation. Here, 7.35, our pH is normal. The PCO2 is still 68. Okay? So we have an alteration in the CO2. We know that's extremely high. They've retained a lot of CO2. Bicarb's 35. So, or it could be, I know it's like, well, how is it partially in one and partially in the other? Well, because that was enough to bring it back to normal. So this is your respiratory acidosis with full compensation, because the pH is normal. We still need to identify that underlying cause. Okay, it's not going to be maintained like this if they're still having so much respiratory failure that their CO2 is that high. They're not going to continue to survive. We've got to fix the problem. We've got to help bring that pH back to normal. We got to fix what's going on with the patient. Okay, so here's our first patient that we're going to look at for case study. John April. He's 24 years old. He had a repair of this inguinal hernia. He's 5'10". He weighs 120 kilos. So you can see kind of I tried to pick a picture where he looked like he probably have, a thick neck. I don't know, 21 inches. I guess that's pretty large neck circumference. And he has a morphine PCA for pain. No known drug allergies. Vital signs are good. He's complaining of incisional pain at his hernia site. And he rates it at 7 out of 10, but he's got the PCA, so we're gonna push in, and we've got orders for like maybe a 2 milligram bolus on the PCA. So patient-controlled analgesia device, it has a lockout. We're gonna have him on oxygen per protocol. We're also gonna have him on a CO2 monitor, so it measures the CO2 levels, and we'll lock it out if those CO2 levels get too high and he's retaining too much acid. So we give him a bolus of morphine, and he's starting to doze off, and we're thinking, okay, we're getting a good response from that morphine. 15 minutes later, family yells out and says, hey, we need your help in here. He's not breathing. And we walk in, and sure enough, he's not breathing. He's having apnea for a few seconds, and he might have some ineffective kind of snorting gasps. And then he's kind of breathing at 12 per minute. But his lips are bluish, and so are his nail beds, and he's lying supine in bed. And we can kind of awaken him and get him to wake up, but he still is very lethargic and somnolent. Okay, so what are you going to do to assess? What do you think's going on with this patient? You think about this, okay? Sarah, what are you going to assess on him?
Well, you want to check his pulse ox. You just gave him the morphine, so it may have depressed his respiratory system. So I'm going to check out how much oxygen he has and an ABG, see if he's retaining CO.
Yes, so what type of acid-base balance are you going to suspect?
Respiratory.
Respiratory, I'm sorry, cut off.
Acid.
Correct, yeah. Yep, with respiratory depression, the CO2 builds up. We would expect his CO2 to be high, and because he's lethargic and kind of somnolent. So we need to assess his lungs, anterior and posteriorly, for adequacy of ventilation. Pulse ox is also needed for oxygenation. So you need to further assess his other vital signs to determine his hemodynamic stability. You know, is his blood pressure also bottoming out, right? And you need to investigate his breathing pattern. And, you know, the patient's symptoms of lethargy and somnolence are suggestive of retaining CO2. So he's got this alteration in his mental status because of that buildup of CO2. So nursing interventions that you should institute. Which intervention must be provided immediately? What do you think, Alexa Anderson?
I would say sit him up, but would you do that after he's had an abdominal surgery, or would that cause pain?
I would.
Okay.
Yeah.
And then,
at this point, airway and breathing trump pain.
okay. And then you would also call the doctor and get an order for an oxygen, probably a simple mask.
Good. Okay. Yes, you're anticipating that he's going to need oxygen. Perfect. What are we
Also
going
an
to
order
do?
for ABG.
Right. Okay. Unless we feel like we can clinically reverse this quickly, you know, maybe we don't need that if you know, clinically we can do something here to reverse this quickly. What would that be?
Naloxone.
Yeah. Who's that?
Sabina.
Sabina. Very good. Yes. Narcan, naloxone. Yes. So like 4 milligrams. But the one thing that we need to remember too is there's a half-life of Narcan, right? And when we give it, we do have to anticipate what's going to happen when we reverse that morphine. He probably will be back in pain, but he will be breathing, right? So like I said, breathing. So yeah, the nurse needs to place the head of the bed up immediately to a level where the patient's lungs may fully expand to help him breathe. You'll need to perform an assessment to determine the underlying cause of the patient's sudden change in maintaining airway and breathing. You know, and this is where you're like calling his name and telling him to wake up and try to take deep breaths, right? You're stimulating your patient. Contact the surgeon with the assessment findings. This is a change in your patient's status, so you need to call SBAR, right? Because then maybe they do want to get blood gases. Maybe he had episodes that in the OR that weren't reported to you. Maybe there's something else going on with bleeding or something that the surgeon would be suspicious of. Maybe you need to change the morphine orders, right? We don't want to do a Josie King, people, right? So yeah, so you need to call SBAR. And remember, in the hospital setting, call for help. Call your charge nurse, call your rapid response team. Don't leave your patient, right? So you're gonna, you know, if you got a bag of masks there, you know, and your patient's not breathing, you're gonna stay, you're gonna beg, you're gonna, you know, perform that supportive care and get help. Give the Narcan, reverse the respiratory depression caused by the narcotic, and further investigation and follow-up the treatment. Maybe he's having underlying sleep apnea. See if there's that history of obstructive sleep apnea because of the neck size and stuff. And make sure you're doing family education and ensuring that the family's not pressing that PCA button for the patient. You know, we can use PCA devices where the patient has a button that they can push and there's a lockout every 10 minutes or however it's ordered, so that you can do a basal rate so that they have like 0.1 milligrams of morphine going in every hour or every, you know, so often, and or every, you know, a minute or so, and then they're pushing the button to give themselves bolus doses. And we can set that up with kids that are maybe 6 years old, as long as they're old enough to understand that if I'm awake and I'm having pain and the light's green, I can push my button and get pain medicine. And we need to make sure that the parents or the family members aren't going to push the button and oversedate the patient.
Miss
So it's
Erickson?
really, yes.
How does that work for documenting? Does it like send a notice to like us, or does it automatically put it in the MAR or something?
So it is an IV pump machine, so it records. So at the end of every shift, the nurse, and you'll learn about this, I believe it's 4th semester, that you go in, there's a key, it's locked, and there's a cartridge of morphine that you put in there, and you set your, you know, you're checking with a second nurse every shift, setting up your PCA, and then at the end of the shift, you clear the amount of morphine that they've used for that shift. Evidence-based practice has indicated that patients get better pain control, and initially they might use more morphine because they're able to get what they need, but they heal faster, and then their morphine use decreases sooner because they're up moving and they're recovering. And so in the whole hospitalization, they're using less narcotic. And, you know, 24 hours, you're weaning them off of the PCA and onto oral pain meds that they're going to go home with. So there's PCAs, there's also epidurals, and then there's other, you know, we got a lot of different tools up our sleeve when it comes to pain medicine. So, you know, you got your Tylenols and your ibuprofens, and then your Toradols, and, you know, those anti-inflammatories that help with pain, and then things like muscle relaxants and sustain the like morphine when you have it where it's like slow release over time, and then so you can give like a small dose over time that's long acting, and then give every 4 hours, give doses in between. So, okay, so good job with that. That's, you know, really when you're talking pneumonia, when you're talking COPD, when you're talking post-op respiratory depression, we're talking respiratory acidosis, and that is the most common exemplar that you're going to see out there in clinical in taking care of patients. Okay, now this little lady is Ms. Clara Dean, and Mrs. Clara Dean, she's 75 years old, admitted to the hospital for small bowel obstruction. Her medical history includes hypertension. She's NPO, and she had an NG tube placed to low constant suction, so she's got secretions draining out. Her IV is normal saline at 83, which is maintenance for her because she's NPO. And she gets Lasix 20 milligrams daily, so you can think in terms of what electrolytes she's losing. And she gets hydromorphone, which is 10 times stronger than regular morphine, right? And 0.2 milligrams every 4 hours is needed for pain. Her morning electrolytes reveal that her potassium was 3.2. So we know normal potassium is 3.5 to 5. So what are the possible causes of a low potassium level?
Would it be her medication?
That's one of the reasons.
From her blood pressure meds.
Yes.
What about because she's getting so many IV fluids? Is she urinating a lot?
What is she not getting in her IV fluid? What's her IV fluid?
I don't remember what the slide said. I'm sorry.
Normal saline.
Yep. Does that have potassium in it?
No.
Very good. Yep. So Yes, so she may have hypokalemia due to her NG tube suctioning, the use of the loop diuretic furosemide, and then the action, right? You're going to call, who are you going to call?
The doctor?
Yes. You're going to call SBAR to the doctor. You're going to report the potassium and give kind of the background, right? She's got the NG draining. She's NPO. She has normal saline running in her IV. And you would most likely recommend replacement of the potassium, probably adding potassium to her IV fluids and getting a repeat serum electrolyte in the morning in your SBAR. What are clinical manifestations that you might see with Mrs. Dean? Bia, what are some of those clinical manifestations? Think of Mr. Morrison.
In regards to a low potassium level?
Yes.
So muscle weakness or muscle pain. I don't know of any others.
Okay.
Abnormal heart rhythm too, I
Yes,
think. Yeah, they
absolutely.
can go into like a different rhythm.
Yes.
I don't know any others.
It actually could also contribute to her decreased bowel motility. So, but you're right with what you said. Initial manifestations are likely to include fatigue, anorexia, nausea and vomiting, muscle weakness, leg cramps, decreased bowel motility, paresthesias, and dysrhythmias. Okay, so, you know, we also know that like calcium, right, helps with the actual muscle fiber and how the muscle fiber functions. So remember with hypocalcemia, it's also a cation that has to do with muscle function. And if you're hypocalcemic and you touch, you'll get the Chauvet sign with the twitching, or if you do the blood pressure and you get the tetany, that's Trousseau's. So you get Trousseau's sign and Chauvet sign. So if you're ever in clinical with me and you have a patient with hypocalcemia and you see that, let me know because I've never actually really seen it in a patient. So I want to see it. So don't get hypocalcemia and hypokalemia confused. Remember that potassium, we're always thinking about the heart function, right? Because of the potassium sodium channel and how that is so important to heart function. So I know that you're all second semester and we're learning this, okay? So this is just learning it. So the more you get exposed to it, the more you hear it, the more you'll know it. Okay, we have one more. Conrad Jackson, he's 28, and he comes into the emergency department. He's severely fatigued and dehydrated. He has a 4-day history of vomiting. So think in terms of acid-base imbalance. During the interview, he describes attending a family reunion and states that the potato salad was probably sitting out all day, right? Ate something bad. Upon admission, his vital signs, his temp is 102.7, heart rate's 116, respiratory rate is 18, blood pressure 86/54. You notice his mucous membranes are really dry. He has tenting of his skin, and he's 28. So if we drew that, you know, on his hand, it should be elastic. You know, elderly people, forehead or sternum, because their hands a lot of times, you know, are lose their tone, lose their elasticity. Physician orders an IV to be started with half normal saline and orders serum electrolytes and arterial blood gas. And here we go, right? We're like, oh, we can't wait. What does it show? What does it show? And our sodium's 150 and potassium's 5.5, chloride's 110, BUN is 42. So that's, you know, our kidney function with the creatinine and BUN, 0.8. Glucose is 86. pH is 7.32. Carbon dioxide, 35, bicarb is 20. His oxygenation arterial sat is 90 and O2 sat's 98, so that's okay there, okay? pH. What do you think about his pH, Susanna?
His pH is a little, he's more on the acidotic side.
Yes, very good. Okay, so he does. He has kind of a mild acidosis. It's not horrible, but it's acidosis. And Letty, what do you think about his CO2? What about his carbon dioxide?
His CO2 is 35, so it's a little elevated.
So remember the CO2, normal is 35 to 45.
35 to 45.
So
okay.
it's within normal limits. And then his bicarb. So remember, what's the normal for bicarb, Letty? Do you remember?
22 to 26.
Yep. So what do you think about that?
It's low.
It's a little low, so he doesn't have enough base, right? So he's probably been having some diarrhea with the vomiting, and he has. So how would we interpret this, Matthew? Matthew Didow, are you there? Okay. Danica, are you there?
I am here.
Okay. So what do you think about his blood gas? What is it showing?
I don't know.
Okay, so the pH is
Low.
Is it?
so it's acidosis.
Mm-hmm.
The bicarb is low, so we don't have enough base. So what kind of acidosis is that?
Metabolic.
Correct. Metabolic acidosis. Is he compensating?
No, because that's still fine.
Right. Not enough, right? It's on the low end of normal. So he might be breathing a little fast, but we'd like him to breathe a little faster, right? I'd like him to blow off a little bit more CO2.
Mm-hmm.
Would be more helpful. So if we can do, even though he's oxygenating okay, if we could make sure that he's not, he's breathing 18, so that's on the higher end of normal. So yeah, and it's not, and the pH, like you guys are saying, the pH isn't horrible, but at least he's not retaining. At least he doesn't have a respiratory thing going on too, right? Because you can, not to throw a wrench in everything, but you can also have a mixed acidosis where you have respiratory stuff and metabolic stuff. So at least he doesn't have that going on.
Miss Erickson, what was the rule again with potassium? Because his potassium's high. So isn't it the potassium follows the hydrogen ions? So like if he's more acidic, then he's going to have a higher potassium level because there's going to be more potassium in the blood?
Yes, exactly. You are correct, because the hydrogen ions are going to get moved into the cell. They're going to displace the potassium out of the cell. So your potassium level is high. But he's also dehydrated, right? So it's going to be, your electrolytes are going to be more concentrated, and then when he gets, rehydrated, that should come down also. So we're going to watch that carefully. But that is the process that's going on. I'm glad that you remembered that. Thank you. And then I'm glad that we are using half normal saline, and we're not bolusing with half normal saline. When you give, like if we're going to give him like a liter bolus or something like that, it's going to be with isotonic IV fluids. It's always going to be lactated ringers or normal saline. But in terms of just maintenance IV fluid rehydration, his sodium is on high, right? So we want to just, the half normal saline sounds appropriate. Glucose is okay. But he does have, so then with metabolic acidosis, we want to look at what's going on with the cations and the anions. With most organizations, we don't include the potassium in that because it's a relatively low number, because most of the potassium is in the cell. But you take the chloride and the bicarb, and on the BMP, so we're going to take, and in this formula, we'll include the potassium for the process of the book. So the chloride plus the bicarb is 110 plus 20. So our anions are 130, right? And then our potassium and our sodium together. So you add sodium and potassium, and that's 155.5 minus 130, and we get 25.5 for an anion gap.
Miss Erickson?
Yep.
His sodium's a little bit elevated. Is that related to anything?
Mostly to dehydration. But
Makes sense.
also, he was vomiting, but then if he's having diarrhea too, so he's losing fluid. It's mostly dehydrational, but it also has to do with that same process. All the he's trying to maintain acid-base balance by moving hydrogen into the cell.
Got it.
That's a cation, so that will stay outside of the cell. But what's important here is to know that he has an anion gap acidosis. So a lot of times with metabolic acidosis, it's affecting your electrolytes in that way. So you'll see that you have more cations than anions circulating in the bloodstream. So you have an anion gap. So a normal anion gap is 12 to 16, and his is 25.5. So I'm just kind of exposing you to this. And so what we would look at is that he has an anion gap metabolic acidosis. So not only are we looking at normalizing his pH and his acidosis, but we're also looking at closing the gap between those electrolytes. And this is especially important in diabetes because it can't be all about the blood sugar. And what's a fun fact to understand about that is if we're just like, if I have a person who's hyperglycemic, if the blood sugar is really high and it's high in the brain and it's high in the body, I can bring down the blood sugar really fast in the body. But because of the blood-brain barrier, the blood sugar will stay higher in the brain. And then all the water in the body will go through the blood-brain barrier to the brain and cause cerebral edema. And the brain, you'll have increased intracranial pressure to the point that it will herniate down the main stem and the patient will die. So when we look at regulating and getting the person back into, out of DKA, out of diabetic ketoacidosis and that metabolic acidosis with that high anion gap, we really, as a quality control measure, we look at closing the anion gap and bringing down the blood sugar slowly. So you need to know how fluids follow in the body and how this whole process, this maintaining of homeostasis works. So isn't that, I just want to kind of share that scenario because I think it's cool to realize, to start to know what you don't know, okay? And is that kind of where you all feel you're at right now? But you will, okay? You're gonna know, when you get done with this nursing program, all of it starts to really fit together. That's why we say trust the process, okay? Right now, you're looking at this and you're saying, okay, I can tell that sodium's high, I can tell that potassium's high. I'm understanding that, okay, hydrogen moves into the cell and potassium moves out of the cell. I can understand that my cations are higher than my anions. I'm adding that chloride and that CO2 together, and I realize that I have an anion gap, okay? When you can see this, and then you see the patient in the clinical setting, it's all gonna start to fit together, okay? But I just want you, the takeaway right now is to know that the electrolytes are affected by acid-base balance. Okay, and this is a good scenario of showing that there's an anion gap. And I put this all in the notes on the bottom, the speaker notes of the PowerPoint, so you can go back and look at all these answers to these scenarios.
I have a question.
Yeah.
So his chloride's like a little high, right? Or her? I can't remember if it's boy or girl. Or no?
Boy.
Because I was just wondering, like, when would it be, when would it be a hyperchloremia or whatever?
Chloridemia above, 100. But remember, he's pretty severely dehydrated, right?
Yeah.
So that's playing into this.
So then you would take that into account. Okay.
Yep, when we rehydrate him with that half normal saline, and he's probably going to need a bolus too. But then once he voids and his kidneys are functioning, we know his kidneys are functioning, then we'd want to start looking at replacing potassium, maybe some D5 normal saline with 28K, because the sodium, the stuff, it's going to come down and we're going to start, it's going to be more dilutional. Okay, I think that was it. Okay, so we interpreted the blood gas, we explained the high potassium, we calculated the patient's anion gap, and the interpretation of the anion gap is that he has a anion gap metabolic acidosis, because his anion gap is greater than 16. It's 25.5. Okay, so 10:30. Let's do one more thing, and then we'll take a break. I think it kicked me out. Why don't you guys, you want to